Well, yeah. So I'm going to deal with the bicoronal flap. And how many of y'all in this audience, not the faculty please, have had some exposure with the coronal flap? That's very good. Okay. How many of y'all have completely understood how to raise a bicoronal flap without making it extremely messy and bloody? Oh, that's nice. Okay, I see one hand going up, so you kind of know that. That's very good. That's a good idea. So that's a good starting point for me to understand how we can explain the bicoronal flap. Now, there are many indications of bicoronal flap. For me, it is mainly the craniofacial surgery, and when I'm doing this surgery in children who are 1 year or 9 months to 15 months, for example, you have to understand that they have only 2.5 cans of Coke volume blood in them. And raising your flap itself can mean that you're putting the child into jeopardy and you don't have enough blood supply now to do the rest of the work. So this is why we kind of then pride upon raising the bicoronal flap, and we then don't let the surgical colleagues, ironically, to raise the bicoronal flap, and we then do it ourselves. So the way to think about the bicoronal flap is, and there will be some difference in opinions as well when we discuss this later, is to try and keep this flap within the hairline and consider the recession of hairline as well. In children, you can actually get a good, pointy markings, and you need them to get reoriented. However, if you do this in adults, it will be very difficult to flip the flap down. So in adults, it becomes a little more curved. You could do curves, or you could do angulated incisions. The choice is yours. I personally find it easier to reorient the flap when the angles are sharper than them being lazy S incisions. Now, to make it much more easier, because I'm a creature of habit, I just want to just go to the theater, start doing things very quickly, and I know where to start what. Take the midpoint, mark a point. Now you need 2 points which are behind the midpoint at the mid-pupillary line. So that is your level of incision here. So that's your middle arm of incision. Then you need one at the lateral canthal area, which is at the temporal area, and that's your other point. And then you join something in front of the helix. So you go there, you go there, you go there, and that's it. That's done. And it makes a lot of sense, because now you know for every patient of yours where you're doing the bicoronal, it's a set points that you're going to use. Midpoint, a mid-pupillary line, somewhere around the lateral canthus area in the temporal region, and just around the helix. And then you join these dots and it becomes easy. And you know what you need to get to, right? So if you are raising the scalp flap without the pericranium, you need to get the skin, the subcutaneous tissue, the aponeurosis, that's regalia, and in the loose areolar tissue is your plane wherein you raise the flap. The pericranium can be left behind. Now again, I will come to that point where you can raise the pericranium along with the flap in some instances, but most of the times, I prefer to keep the pericranium on the bone itself. So like I said, in an adult, I'm probably giving a lazy S incision, trying to keep the apex still slightly pointy so that I can reorient the flap. You could make cross hatches, make it easier, and unfortunately, even in adults, I would not want to shave the head completely, but the neurosurgeons take the call there, so they shave the head. But if you see in a child, I just just take a 1 inch 1 inch razor and just shave the part of interest. So here you go. This is where you want to enter, right? After you've scored the skin, you could make the incision deeper, but again, if you start making the incision deeper right in the beginning, it starts bleeding immediately. So what you want to do is score the skin and introduce your Colorado needles in a point which is of your choice in that below the galea. As soon as the Colorado needle is below the galea, can you notice these areas where the blood vessels is, right? What you need to do is enter that area and then start flicking it out. Can you take the volume off, please? I may be abusing in that. So, thanks. So, what I'm trying to do is get under the subcutaneous tissue beyond the galea and raise the flap. Now, care has to be taken to not damage the hair follicles at the edge because you are using the Colorado needle, and that is something that Arun Pandasar will also explain. That if you are trying to go too close to the edges of your scalp incision with the Colorado needle, the potential hair loss in that area will be more. Already with your incision, you are causing some alopecia. With your cautery, you will cause more alopecia. Once you've done that, I need that slider again. Can I get the slider?
What are your cautery settings?
So the cautery is at around 25, so not too much. And it's a mix of cut and coag. So while I'm flicking, so once you enter the plane, you flick it in the upward direction so as to coag the blood vessels which are in that plane, which you can see between the subcutaneous tissue and the galea. The bar is not coming because if I keep playing like that, it will become very boring. Okay, show it in. Okay. Right. So we've done with that. I'll do this. Okay. So once you get into your planes, yeah, the only area where I take some time is the temporal region because it's slightly more vascular, and you also don't want to miss the planes there. Like she was explaining, if you notice, after this just trace this line there, which is the line in red, the galea aponeurotica is going down and becoming the temporoparietal fascia, the line in red, right? Now, when you enter that area, it starts becoming a little fuzzy because you want to be below the temporalis fascia. You don't want to be in the temporoparietal fascia, otherwise you will start injuring the nerves there, which you can see. So you get into the galea aponeurotica, that layer, which is now splitting into and becoming the temporalis fascia. This is also important for your Gillies approach. You know, you go skin, subcutaneous tissue, you see something shining, you start introducing your elevator, and you're actually in the wrong plane. You're above the arch, and you're in the nerves. You want to go just above the muscle, so that you're below the arch, and your nerves are safe. That's very simple, very, very easy to understand. Now, once you start raising, and you see what I'm doing, I've raised the central part, both sides, not raising the whole segment forward, doing temporal areas on both sides. This is about to minimize the bleeding. We don't put draining clips because again, if you put draining clips, again you're compressing the edges. So somebody will ask whether you put draining clips or not. I don't put draining clips. I do, however, put some hemostats to keep the scalp tight when they're dropped open. So that is something that we do to make sure that the hemostats catch the galea layer. And once you catch the galea layer, it becomes easier for you to identify the galea layer as well. So after that is done, on both sides, like I mentioned, you get some ooze typically in the temporal region. And once this is done, this is where I want to show you what we do. You see when you keep your skin hooks, when you keep your skin hooks, and the reason why a lot of times you find surgeons getting frustrated with the assistant is because of the direction of the skin hooks. The direction of the skin hooks should keep the scalp flap taut and up. If it is slack and downwards, you will never get into the layer. You want to keep it up, so you stretch it out so that it's easy for you to see the loose areolar tissue, which is where you want to be. And that you keep readjusting your skin hooks, and once you get enough scalp, you can start holding it yourself. And you hold it and you keep it up, and you keep seeing that area which is your area of the dissection, and that's pretty much it. So you then can expose very easily without actually having any interferences. Be in the plane. Like I mentioned previously as well, if you want to keep the pericranium thick and nice for your future use, it's best to make sure where your level of dissection is. However, a lot of surgeons want to raise the pericranium along with the flap. So if you have left the pericranium on the scalp, you have two options with it. You can, if you want to expose something in the frontal bone, and you don't want to raise the entire pericranium, because every time you raise the pericranium flap, you'll also have more bleeding. You can make an incision right there, and you expose the frontal bone, and you can do your bony fixations and bony work right from there. However, if you need the pericranial flap for your obliteration of the anterocranial fossa, your sinus or whatever, you raise the full flap and then you can decide what the pericranial flap needs to be done. In most instances, in craniofacial surgery, when I say craniofacial, when I transcranial surgery, we try to keep the pericranial flap available for emergency use, because we can have a large bleed and then we need something to patch that up, and that's where the pericranial flap comes handy. Now, so when you look at the where was I? Yeah. So when you look at the pericranial flap and it is anteriorly based, there are two things I would want to highlight. I have left the temporalis attached on the head if I am not doing any work on the temporal fossa there. However, if you want to access the pterion, then you take the temporalis along with the pericranium. Because once you detach the temporalis, it is extremely hard to reattach the temporalis. So you try to preserve the temporalis attachment whenever possible. However, in situations where it is not possible, you can take it with the pericranial flap. Because if you don't attach the temporalis muscle back, you get temporal hollowing. So these are the things that you will have to know. And like we were seeing in this diagram, that if you want to prevent any injury to the nerves, you have to make sure that you are within the temporalis fascia and not in the temporal parietal fascia. Is that it? That's all I think I would like to explain. There's nothing much that I would like to highlight beyond this point. Thank you. So when you raise the pericranial flap, the bone bleeds. So you have to keep bone wax handy, and you can start putting on the bone as it is bleeding. The areas where the pericranial flap is the most sticky is the sutures, and that is where it will be very hard to get the pericranial flap again out. But you know what the fun part is? Because you all do a lot of periosteal flaps, the pericranial flap becomes second nature too. It is not very difficult for us to raise the pericranial flap. So I think Mr. Edwards also highlighted subperiosteal, pericranium. These are things that are very dear to us. We should be able to raise it every time. Yes, sir.
You said you would maintain the temporalis with the gale.
Yes. Yeah. So he's asking, how do you take the temporalis flap along with the pericranium? So you do an H incision. So you take the incision beyond the temporalis attachment and then raise the temporalis muscle with the pericranial flap anteriorly. No, so you have a central pericranial flap. Then you have two pericranial flaps with the temporalis muscle. Yes, separate. And then when you suture, you can suture the pericranial flap together so that you have some robust attachment. Because otherwise you will have to attach the temporalis muscle to the bone somewhere.
Yeah, what if you're using the pericranium in the front, but you do not have it with the vertexes? And you don't
so when you do that, you split the pericranial flap. You take a lobed pericranial flap. If you're using the pericranial flap, don't take the entire thickness of the pericranium flap. You take a central strip of the pericranium and then strip it out. So you still have the bilobed pericranium which can be used to suture. So this is something it's a very good question, because the fear is you don't want temporal hollowing. Yes. And if you have if you don't have any pericranium left, then you have to probably stitch it
what
to your bone.
I take a stitch and cross over to the other stitch
Yes.
just like a sling.
So again, every stitch is going to snap at some point. And when it snaps, it retracts. So yeah.
Questions?
Any question?